we're diving into a topic that is absolutely fundamental for my occupational therapy colleagues, the art and science of splinting. So what exactly is splinting? At its core, splinting, or more accurately orthotic fabrication, is the process of creating a custom device to support, protect, or correct a part of the body, usually the hand, usually the wrist, usually the arm. Think of it as creating a personalized external skeleton for a specific therapeutic purpose. It's a skill that blends deep anatomical knowledge with a creative, hands-on approach to problem solving. It's a precise medical intervention. Why is this so important in the world of occupational therapy? Well, OTs are all about helping people engage in the meaningful activities, the occupations of daily life. An injury, a neurological condition, or a chronic disease can throw a major wrench into a person's ability to do simple things we often take for granted, like buttoning a shirt, holding a fork, or typing on a keyboard. A well-designed splint can be the key that unlocks that person's potential. It can reduce pain, prevent further injury, support weak muscles, and ultimately restore function, allowing patients to regain their independence and get back to living their lives to the fullest. It's a powerful tool in your therapeutic arsenal. The impact of a properly fabricated splint can be truly life-changing. Imagine a patient with severe rheumatoid arthritis whose hands are so painful and deformed that they can no longer grip a pen to write to their grandchildren. A custom-made resting hand splint can provide the necessary support to reduce inflammation and pain, preserving the integrity of their joints. Or consider a construction worker who has sustained a wrist fracture. A splint immobilizes the area to ensure proper healing, but it's designed in a way that allows their fingers to move, preventing stiffness and maintaining as much function as possible. This is where OTs shine, by looking at the whole person and their goals. So as we get into the nitty-gritty of splinting, I want you to remember this bigger picture. You're not just making a device, you're crafting a solution. You are directly influencing a patient's recovery, their comfort, and their ability to participate in the world around them. This guide is designed to give you, especially if you're a new OT, a solid foundation. We'll walk through the core principles, the most common types of splints, and the practical tips you need to feel confident. Let's get started on mastering this essential skill and making a real difference for your patients. Alright, before you even think about heating up a sheet of thermoplastic, you need to understand the why behind every splint you make. I like to break it down into 4 core principles: protection, support, positioning, function. First up is protection. This one is pretty straightforward. After an injury, like a fracture, a tendon repair, or a burn, the affected tissues are incredibly vulnerable. A splint acts as a shield, guarding the area from accidental bumps, excessive movement, or external forces. Think of it as a bodyguard for the injured part, ensuring a safe environment to mend. Next, let's talk about support. This principle is crucial for patients who have muscle weakness or joint instability. Conditions like a stroke, a peripheral nerve injury, certain types of arthritis can leave a patient unable to hold their wrist or hand stable. A supportive splint acts like a scaffold, providing external stability. For example, a patient with wrist drop due to a radial nerve injury can't extend their wrist. A splint can hold their wrist in a neutral or slightly extended position, which is essential for being able to grasp and release objects effectively. This external support compensates for internal weakness. The third principle is positioning. This is where things get really precise. The goal is holding a joint or series of joints in a specific alignment to achieve a therapeutic outcome. This might be to prevent contractures, the permanent shortening of muscles or tendons. Contractures can happen when a joint is immobilized too long in the wrong position. Proper positioning can also reduce inflammation and pain. For example, positioning a hand with carpal tunnel syndrome to open the carpal canal and relieve pressure on the median nerve. Show functional position diagram. Finally, the principle of function. A splint should, whenever possible, enhance a person's ability to perform tasks, not hinder it. It's a delicate balancing act. Immobilize what must be immobilized and free what can be freed. Minimal immobilization for maximal function. For instance, a splint for a boxer's fracture might immobilize the metacarpal bones, but it should be designed to allow the thumb and index finger to meet for a pinch grip. Always ask yourself, how can I design this splint to solve the primary problem while allowing the patient to do as much as possible? Now that we have the principles down, let's open up the toolbox, visual, look at some of the most common types of splints you'll be making. These are the workhorses of any OT clinic. First on the list is the resting hand splint. This splint is designed to support the wrist, fingers, thumb in what we call a functional or resting position. It's typically used to reduce pain and inflammation, like acute rheumatoid arthritis or a crush injury. The goal is to give the entire hand a break, preventing stress on inflamed joints and stopping the development of deformities. It's a foundational splint every therapist should know how to fabricate. Next up is the thumb spica splint, also known as a thumb immobilization splint. Its primary job is to immobilize the thumb joints, carpometacarpal joint, metacarpophalangeal joint. You'll often see this used for de Quervain's tenosynovitis or for arthritis at the base of the thumb. By stopping the thumb from moving, the splint lets irritated tendons rest and heal. The key is positioning the thumb so the patient can still use their fingers for gripping, preserving hand function. Another incredibly common one is the wrist cock-up splint or wrist immobilization splint. This splint supports the wrist in a neutral position or slightly extended, about 10-20 degrees of extension. It leaves the fingers free and the thumb free to move. This is your go-to for many conditions: carpal tunnel syndrome, wrist sprains, distal radius fractures after cast removal. Holding the wrist slightly extended maximizes finger function for grasp and release, and for carpal tunnel, it helps relieve pressure on the median nerve. A good example of balancing immobilization with function. Finally, let's touch on finger splints, which come in many shapes and sizes. Simple gutter splint to immobilize a single finger joint after a sprain, or a complex dynamic splint using rubber bands or springs to regain motion. For example, mallet finger. You can't straighten the fingertip. Treated with a small splint holding the tip in extension for weeks. The beauty is specificity. They target the exact problem area while leaving the rest of the hand free. Great for compliance and function. Choosing the right splint is a critical thinking process, not just picking one from a list. It starts with a thorough patient assessment. This isn't just about looking at the injury, it's about understanding the whole person. What is their diagnosis? What are the specific doctor's orders or protocols? What are the patient's goals? What activities are they struggling with? What do they need to do at home? What do they need to do at work? What do they need to do for their hobbies? A splint that prevents a musician from playing their instrument might be technically correct, but practically a failure. Your assessment is the foundation for everything that follows. Now analyze the problem from a biomechanical perspective. What is the root cause? Pain, weakness, instability, stiffness, or a combination of these? Let that analysis guide your design choices. Pain from inflammation. Consider a resting splint to immobilize. Weakness causing wrist drop. A supportive cock-up splint is logical. Goal to gently stretch a stiff joint. Consider a static progressive splint or a dynamic splint. Match the splint's purpose to the patient's specific problem. Now think about specific design. Consider the bones. Consider the joints. Consider the ligaments. Consider the tendons. Consider the nerves. Key principle: the three-point pressure system. Every splint applies pressure at 3 points to maintain position. Identify where forces will be applied to be effective without causing skin breakdown. Wrist cock-up example: pressure on the back of the forearm, pressure on the palm of the hand, pressure on the front of the forearm to hold the wrist in extension. Finally, consider practical real-world factors. What material will you use? A rigid, low-temperature thermoplastic gives firm support. A more flexible material may be better when some movement is needed. What is the patient's lifestyle like? Someone who works in a dirty environment needs a splint that's easy to clean. What is their cognitive status? A patient with memory issues needs a splint that's simple to put on and take off. Considering these factors is the difference between a splint that gets worn and one that ends up in a drawer. Creating a splint that is technically perfect but uncomfortable is a recipe for failure. If it hurts, digs in, feels awkward, your patient simply won't wear it. That's why achieving a comfortable fit is paramount. The first rule is to respect the anatomy. Pay close attention to bony prominences of the hand and wrist. Ulnar styloid, the bump on the pinky side of the wrist. Distal palmar crease. Mold around these areas, not on top of them, to avoid pressure points. Always flare the edges away from the skin to distribute pressure and prevent digging. Next, think about hand mechanics. Preserve the natural arches, longitudinal, transverse. A splint that flattens these arches will feel unnatural and increase fatigue and strain. When molding thermoplastic, use your own hands to gently cup the patient's hand. Encourage the material to conform to natural contours. This makes the splint more comfortable, stronger, and better at distributing pressure. A flat splint is a weak, uncomfortable splint. Hygiene is critical for comfort and compliance. A splint worn many hours can cause sweat, bacteria buildup, skin irritation. Choose materials wisely. Most thermoplastics clean with soap and water. If adding padding or lining, removable and washable, or closed-cell foam that doesn't absorb moisture. Teach the patient to clean the splint and skin daily. A clean splint prevents secondary problems like rashes, infections. Those lead to non-compliance. Finally, the strapping system is as important as the base. Straps hold the device. If they're wrong, it fails. Use wide, soft straps to distribute pressure and avoid a tourniquet effect. Avoid straps over sensitive areas or bony prominences. Velcro placement is key. Ensure the patient can manage straps with their other hand. A perfectly molded splint with poor straps is useless. Take the extra time to get the straps just right. It pays off in satisfaction and outcomes. You could fabricate the most beautiful, biomechanically perfect splint in the world, but if the patient doesn't understand it, it's just a piece of plastic. Patient education is not an afterthought. It is an integral part of the splinting process. Your job isn't done until the patient and their family can confidently tell you why they have the splint, how it works, and how to care for it. Start by explaining the purpose in simple, clear language. Avoid medical jargon. Instead of saying, "This will prevent a flexion contracture," say, "This will keep your fingers straight so they don't get stuck in a bent position." Next, you must provide a detailed wearing schedule. This should be written down for the patient to take home. Be extremely specific. 24 hours a day, 7 days a week, only at night, during specific activities, for how long each day. Ambiguity leads to confusion and non-compliance. Explain the reasoning behind the schedule. For example, "We want you to wear this at night because that's when your hand tends to curl up, and this will give it a nice, long stretch." Also, be sure to specify when the splint should be removed, such as for bathing and for performing specific exercises that you have prescribed. A crucial part of your education session is teaching the patient to be their own advocate by monitoring their skin. Instruct them to check their skin every time they take the splint off. Show them what to look for. Red marks that don't fade after 20 minutes, blisters, rashes, or areas of broken skin. Give them clear instructions on what to do if they see any of these warning signs. They should know to call you immediately. Empowering the patient to be an active participant in their care builds trust and prevents small problems from becoming big ones. Finally, make sure the patient can demonstrate everything back to you before they leave. Have them show you how they put the splint on correctly and take it off correctly. Ask them to repeat the wearing schedule and the precautions back to you in their own words. This teach-back method is incredibly effective for confirming their understanding. Provide them with written instructions, complete with pictures or diagrams if possible, and your contact information. A patient who leaves your clinic feeling confident and knowledgeable is a patient who is set up for a successful outcome. Your expertise is only as good as your ability to communicate it. So we've covered a lot of ground today.